translator, Melissa and myself will do our best not to switch from French to English and from English to French. We know it's a nightmare. So we'll be presenting in English, but we're both fluent in French. So if you wanted to ask questions, and we will have time for questions at the end, please don't hesitate to do so in French. We'll be able to respond in French as well. So welcome everyone to this session on health financing. This session is being presented by myself, Nouria Brikci. I work for the London School of Hygiene and Tropical Medicine, where I head the Data Analysis Center on Health Financing for the Countdown, and by Melisa Martinez-Alvarez, who is online. Hello, Melisa, who's a long-standing staff member of LSHTM and has been instrumental throughout the years of the Countdown in ensuring that it was responding to what the country needed and in undertaking all of the analysis. The reason for this workshop today is that we've realized throughout the years and in the latest meeting we all had in Kigali that sometimes what health financing meant wasn't that clear for everyone. So we thought that it might be a good idea to firstly present to you some of the key concepts of health financing, and that's what we're going to be doing today. We're going to be talking through the, if my slides move, yeah. We're going to be talking to you about why health financing matters, why we think it matters, and hopefully convince you that it really does matter in all of the work that you do, whether or not you're a health financing expert. And I actually think that most of you on the call today are not health financing experts. And that's exactly what we were hoping for. We were hoping to reach out to those who may feel maybe a bit scared by the term financing, might think that to be able to understand any of it, you needed to be health economists. And hopefully we will demystify this today and show that health financing is relevant to all of us, whether we are doctors, nurses, epidemiologists, whoever it is, as long as you work in health, you should have an understanding of financing, and it really is not rocket science. So in the hour that we have together today, I will spend a little bit of time talking to you about why financing matters and how we study it, and talk you through some research questions that you may feel are relevant to your context. And I'll speak for about 20 minutes. And Melisa will then talk to you about the data that we do have available to respond to the research questions that I will have highlighted. And then we'll talk to you about the next steps and some other webinar that we're hoping to have to further illustrate what all of this means. I hope I'm not speaking too fast for the translator, but since I cannot see anything happening, I can't see any thumbs up or anything, I will assume that this is fine. Okay, so let us start with then why health financing matters. The first thing that I wanted to emphasize is that when we talk about financing, we're not just talking about whether money comes from user fees or comes from taxes and how much money there is for health. We're actually talking about a lot more. And the way that we normally think about health financing is by thinking about three functions of financing. That's what we call them, the functions of financing. The first is the one that is very familiar, I'm sure, to you all, is how to mobilize resources for health. There are many different ways of raising resources for health. There are, for example, user fees that I have already mentioned, but there's also taxes, all sorts of different taxes. There's insurance. It can be voluntary health insurance. It can be insurance that is led by the government. You also have donations from philanthropists that come and increase the envelope that is available for health in your country. And it is this envelope that is then ideally pooled, and that's the second function of financing. And pooling is just bringing all these resources that are collected together, all the prepaid resources together. And pooling is very important because it is through pooling that we manage to ensure that the rich can cross-subsidize the poor, that the healthy can cross-subsidize the sick. It is by bringing the resources together that we're able to express some form of solidarity towards each other. If all we do is pay for our healthcare through, for example, user fees, we're not expressing any solidarity with anybody else. If we have the money, we can access healthcare. If we don't have the money, we can't access healthcare. And the function of pooling is really meant to try and ensure that there is solidarity between people. But once these resources that have been mobilized and pooled are then available, we need to use them to purchase services. And again, the word purchasing is often misunderstood. And really what we mean by purchasing is the way in which the resources that have been pooled are used to buy from providers the services that we need. And this function of purchasing is very large, and it covers a lot of issues. For example, it is through the purchasing function that you're going to be thinking about the benefit package that you should be providing to the population. Will you be purchasing a very large benefit package, or will you be purchasing a small benefit package? And it's this purchasing function that allows for this reflection to happen. It is within the purchasing function that we also get to think about whether we should be using only public providers or whether we should also be using private providers, and what kind of contracting arrangements need to be in place between the purchaser, which can be the Ministry of Health, but can be donors, can be directly Ministry of Finance, can be a National Health Insurance Agency, and the providers that can be public or private. All of these functions, the revenue collection, the pooling and the purchasing, and the definition of the benefit package, help you advance towards universal health coverage. And I'll show that here. It is through thinking about those three financing functions that you're able to increase the population that you cover, increase the services that you provide, and increase the financial protection of your population. And these three financing functions, therefore, it can improve the equity and the efficiency of your health system, which ultimately will translate, we hope, in better health outcomes, in greater financial protection, and in greater responsiveness of the health system towards its population. If we don't think about how resources are raised, for example, we may not be able to improve equity. And this example here shows that if you have a high out-of-pocket, or rather, the higher the out-of-pocket, the worse the health outcomes that you're going to get in your country. At the beginning, I told you that there are many different ways of raising resources for health. And I've told you that you can have user fees, and user fees are a big part of out-of-pocket. I told you that you could have insurance. I told you you could have taxes. And all of the evidence that is available at the moment really tries to say, if you want to achieve universal health coverage, if you want to improve equity, but also efficiency of your health system, you need to move away from user fees, les paiements directs des ménages, and you need to move towards greater level of taxation or of insurance. Yeah, and it's a big debate which we can have in a moment. This just again emphasizes the point that where you have high out-of-pocket expenditure, you have worse health outcomes. And this is the example of Malawi that maps out where the highest out-of-pocket expenditures are, the higher neonatal under 5 mortality rate is. Here we see that so that was about the revenue mobilization. This is just to show that the pooling, which I explained as being this expression of solidarity between population, is also very important if we want to progress towards universal health coverage. And this graph just shows that the countries that have the highest level of pooling of health resources progress the best towards universal health coverage. And maybe you can find your country in this, in these examples. And the last financing function that I mentioned is the purchasing. And so within purchasing, as I explained, there are many different areas of importance. The first is the provider payment mechanism that is going to be used. Are you going to be paying your providers through fee-for-service, for example, which is a reimbursement every time that a provider provides a service? You, as the Ministry of Health, for example, or National Health Insurance, you will reimburse them. Will you be using some form of performance-based financing? Will you be using some form of capitation? There are many different ways of paying providers. There's many different provider payment mechanisms. And each provider payment mechanisms has its strengths and its weaknesses. For example, we know that fee-for-service, which is very widely used in a lot of the countries where we work across Africa, but not only, we know that fee-for-service has a negative impact in that it encourages supplier-induced demand, i.e., if you tell providers that you will reimburse them no matter what they do, they will push for those services that will get them the highest fee reimbursed. So, for example, a woman who might need a normal delivery will be encouraged to have a C-section because a C-section is reimbursed at a higher rate than a normal delivery. But every single one of those provider payment mechanisms have, as I said, pros and cons. So really nowadays what we work on is trying to think about how you can combine them so that the incentive that each provider payment mechanism expresses, they all align with each other. So that's a big debate. But as I said, purchasing is not just about provider payment mechanism. It's also about the type of contracting arrangements that you have in place. It's also about the data.
Take 2 minutes, 10 minutes.
It's also about the data that you need to be able to ensure that you align your incentives exactly to what you want. So this purchasing matters. Really, what I've been trying to show here is that you have 3 financing functions: mobilization, pooling, and purchasing. That's what when we talk about health financing, that's what we talk about. And every single one of these functions has an enormous role to play in terms of progressing towards universal health coverage. And so whatever perspective you take, whether you're an epidemiologist, a doctor, you need to have even a basic understanding of these things because they will impact you. If you are a health provider, if you are a nurse, how you are getting paid matters. And it is by engaging with the purchasing question that you will be able to understand why you're being paid in the way that you are and what you can do about it. Now, there's different research questions that we, within the Data Analysis Center of the Countdown, can help tackle. Some of these questions, I will list them relatively quickly now, are, for example, where are the resources going? We know that some countries, for example, Sierra Leone, where I was just working, they get quite a lot of resources, but then where are the resources going? Are they staying at the level of the Central Ministry of Health, for example? Are they being distributed across the different districts? Are they being allocated to health programs that are the most important? How are those resources being spent? Is part of the analysis that we can support you with as part of the DAC. So this whole question of resource tracking is key. Whether or not aid is used in an effective way. So we know that donors have a tendency to focus on their own programs and to bypass potentially this, not just potentially, sometimes bypass the systems of the government. So we can help in understanding how aid is being allocated and whether or not it's being aligned with national government policies and whether or not it is effective. There's a whole host of analysis that can be undertaken in relation to equity. So are the most vulnerable benefiting the most from the domestic resources, or are domestic resources being captured by the richest, who may be in cities, in urban areas, and hence benefiting more from hospitals where more resources are being spent, for example. And we can also help at a less granular level in looking at how much the country is spending per capita as a proportion of GDP, and we can help in analyzing this across time, and we can do this either for a specific country or for specific regions. And these measures are important to know whether a country is spending $3 per person per year or $100 per person per year is important, because you will know whether or not you can have the ambition of universal health coverage or not. If you're spending $3 per person per year, it won't happen. If we know that a country is spending 2% of its GDP on health, whilst globally we know that to achieve a minimum benefit package, to achieve universal health coverage with a very simple benefit package, we know we need at least 5% of GDP. If you know that in your country it's 2% of GDP, you know there is a gap. And it is by having these numbers that you're able then to advocate your Ministry of Finance, your president, or whoever needs to be lobbied, advocate for more resources for health. But if you do not have these numbers, and if you don't know the trends, then it's very difficult for you to argue that there is a need for more resources. The type of analysis, again, that we can undertake, they are from the perspective of citizens, we can focus on external financing, on aid, and we can look at government, or we can look at insurance. And for each of these, there's different potential questions that can be touched upon, and there's different data that we can use to be able to answer those questions. At this stage, the ambition is not that you are going to be able to do this, but at this stage, our hope is that you see the value of asking questions related to health financing. And then we can work together in either trying to answer them or in giving you guidance as to how you can answer them directly. I'm going to pause here, and Melisa, I'll hand over to you for the rest of the session.
Great. Thank you so much, Nouria. I hope you can all hear me. Thank you for a very clear overview of the health financing systems and the types of questions that we can ask. So in my part of the talk, I'm going to focus on the data, particularly the data that's already publicly available that we can use to answer the questions that Nouria has outlined. Next slide, please. Thank you. So I'm going to talk about 4 different sources of data. The first 3 are data on aid or external financing. I'm going to focus specifically on RMNCH because this is the focus of the countdown, although I will at some points also discuss data that's available overall for the health system or for other priorities. So the first source I'll talk about is the CRS, the Creditor Reporting System. So it's run by the, yes, it's fine. You can go to the next slide. It's run by the OECD, the Organization for Economic Cooperation and Development, and it's the main source of data for external financing. There are other sources that you might see in the literature, like the work of AData or the work of the Institute for Health Metrics and Evaluation, but actually a lot of their work is also based on the CRS. So that would be my recommendation as a starting point for any analysis you want to do on aid financing. So data are reported by 50 bilateral donors, 65 multilateral donors, which includes the UN, and 42 private donors. It is relatively complete for the time period between 2002 and 2023, although it is true that it's more complete in more recent years. It is a huge data set. It has between 200,000 and 300,000 data points per year because the data is very granular. It's available at the project level, and it covers all sectors, not just health. The CRS categorizes aid for health, also aid for water and sanitation, and for humanitarian sectors, and it divides this into subsector areas. And this means that it's not always easy to perform RMNCH specific analysis just using CRS data. Next, please. So here, I just want to show you what the CRS data looks like. So this is the Data Explorer, which you get if you just type OECD Creditor Reporting System on Google. You will get given this sort of interface. So on the left, you will see there are several filters. So you can choose your time period. You can choose which donor or donors you want the data for, which recipient countries, which sector. As I mentioned, you have health, water and sanitation. You have several different sectors that are relevant to RMNCH. You can select your measure. So you might want to look at official development assistance, which is aid. You might want to look at loans, etc. You can look at the channel. So you can select data to see how much of aid is delivered through governments, for example. You can look at the modalities. So you can, for example, if you're interested to see which modalities are used or to compare modalities between different countries, you can look at basket funds, different pooling mechanisms, etc. Next slide, please. So I just to show you what it looks like, I selected the time period of 2019 to 2023. I selected all DAC countries as donors. I selected all sectors, aid, and in constant prices. And then just to show you what kind of data you get. So you get a table. I mean, this was much longer, but I'm only showing you the top. So in this selection that I made for each of the countries I selected, you get the total aid that each of these countries received. You can also ask the Data Explorer to chart the data. Next slide, please. So if you just click on chart, you can select the type of chart you want. You can, again, using your filters on the left-hand side, decide what data you want to show. And this is one very simple graph that you can get. So here I selected Tanzania as a recipient country, and I selected family planning as a sector or subsector, priority, aid, and then you can look at the kind of the different donors in the different years and how much they're financing. So you can begin with their Explorer to do some analysis if you're interested in your own country, in a number of countries in the region, or if you're interested in a donor to see the trends over time. But if you want to do more in-depth analysis, then my advice is that you download the data set. So next slide. If you click on the download button on the right-hand side, it will have like a pop-up, and here you can select which year or years you want the data. So you have a different file for each of the years. As I mentioned earlier, these are huge data sets. So for each year, you have about 300,000 data points. You have to select the year, and then you can do your filters once you have downloaded the data. Thanks, next slide. So now we're going to move to the Muskoka 2 estimates. So Muskoka 2 is an algorithm we developed in Countdown, and this work was led by Catherine Pint, who some of you might know. And it's an algorithm that it's applied to the CRS database. And it generates estimates of the monetary value of aid for maternal and newborn health, for child health, and for reproductive health. And it includes aid directly directed to reproductive health, family planning, etc. But it also allocates a percentage of aid towards sectors that are relevant to RMNCH, including HIV, malaria, TB, basic healthcare, health systems, etc. Because it kind of takes like a wider health system approach to RMNCH, and it recognizes that if, for example, you're spending money on human resources, that is also going to help improve reproductive health. And these percentages have been estimated through wide consultations, document analysis, etc. And the Muskoka 2 estimates are available as an Excel workbook, and I'll show you the site in a minute, but it's available from the London School of Hygiene and Tropical Medicine website. Thank you. So there is a global data set, which includes key data for all recipients, so millions of records. For initially, the data was available for the 2002 to 2019 period, but it's been updated and we'll soon have it up to 2023. We have indicators for reproductive health, maternal and newborn health, child health, and RMNCH in total. We have these as totals, but also per relevant population. So this allows for analysis if you want to look at equity or targeting according to need. So the data set has data for every country, for every year, from 2002, on aid for reproductive health per woman of reproductive age, aid for maternal and newborn health per birth, and aid for child health per child under 5. And for each of these estimates, you can disaggregate it by year, by donor, by recipient country or region. I will send you, yes, I can see your comment. I'm going to show you the link in a minute. So this is an example of an analysis you can do using the data set. So here we have a number of countries, and we have the time period from 2002 to 2019, but this will be available very soon until 2023. And we have the trends in child health, maternal and newborn health, and reproductive health, and other aid that could not be directly coded to RMNCH. And this shows one of our publications that we've produced from this data set. Next, please. So how it looks, and I am going to show you the link in a second, but this is the Excel workbook. So you start here in the tab that says start here, and here you have a little bit of a description of the different tabs, the figures, etc. The tabs are color-coded into blue, yellow, and green. The blue tabs are figures, the yellow tabs are analysis, pivot tables, and the green are the actual raw data. So I'm just going to show you one of each now. As an example, so here's a figure. So you get data, the data will be linked. And here it shows, I don't know which country this is for, but it will say it on the data sheet. And it just shows you the different levels of aid across the countries. If you then click on the yellow tab, you can see the pivot table that's used to generate that graph. And then if you click on the green tab, next slide, please, you can actually see the detailed database, the data that it's that this is drawn on. And then we have some country-specific data sets. These are very similar to the global data set, but they allow for more in-depth exploration because they include more data. So, for example, we produced a database for Uganda with data from 2009 to 2018, and that had about 25,000 data records. We are currently working, I think Pauli and Peter are both here, and they're leading this work, but we're currently producing data sets for Senegal, Cote d'Ivoire, Tanzania, Malawi, and Zambia. If you're interested in having your own country data set, then do please get in touch. The country data set includes the same data as the global data set, but also project title, short description, long description, channel of delivery. So if it goes through the government, NGOs, etc., and modality. If you want to see if it's done as a project or if it's done as a basket, sector budget support, etc. Next, please. So this is what it looks like, very similar to the global data set. It has the same color coding. You can see that the additional analysis that are possible are figures 8, 9, and 10, so the channel, the modality, and the basket details. Again, you have the blue, the yellow for the pivot tables, and the green for the raw data. And you will see here that the raw data includes some extra columns and some additional data. Thanks. Next slide. So this is where you find it. It's at the data compass of the LSHTM website. And if you require more information, you can get in touch with any of us or with Catherine Pitt, who has led this part of the work, and she's fluent in English and in French. So feel free to contact us or her if you need any assistance with using this data or downloading it, etc. Thanks. Next. So the final source of data I'm going to describe is the Global Health Expenditure Database of the World Health Organization. Now, this has data on health expenditure for 194 countries. I think it's almost every country in the world. Data are available from 2000 to 2023 in theory, but they're not complete for every year for every country. And here you can find data on sources of health financing, financing mechanisms, and expenditure priorities. So this is what the interface looks like. So again, as with the CRS, you have indicators and data filters on the left, so you can choose your indicator, your countries, your years, and the units of expenditure. So in your indicators, first you have aggregates. So you can look, as Nouria was saying, you might want to know the total amount of health your country is spending on health as a total, as a percentage of GDP. Remember, you need 5% as a minimum to achieve universal health coverage for a basic package. You might also want to look at it as a per capita basis, or you might want a bit more information on the financing sources, so not just the total, but where is it coming from? Next slide, please. So here, click next. There are a number of indicators that Nouria has talked about. So first, we have the different sources. So we have government expenditure, so tax-based expenditure. We have out-of-pocket. We have health insurance, and we have external expenditure. And you can have them as total per capita or as a proportion of total health expenditure. And you also have government health expenditure as a proportion of total government expenditure. And you might know this is one of the international targets to encourage governments to spend more on health. And they signed the Abuja Declaration in 2001, where they said they would allocate at least 15% of their total budget to health. So this database includes this indicator, which can be very useful for holding governments to account for this. And you can look at disease and conditions. So if you are interested in RMNCH specific data, click next, please. There are a number of indicators. So under reproductive health, there is data on maternal conditions, which actually includes maternal and newborn health, and also contraceptive management, which is essentially family planning. There is also data on nutritional deficiencies and immunization programs, which mostly target children under 5. This is what it looks like. So once you've chosen your indicators, your years, your countries, etc., it will show you a table. So here I have selected Benin, and I have selected a couple of indicators. And then for each of the years, it will show that I have selected, it will show me data, and you can choose to download it as an Excel workbook and work with it, or a PDF document if you like. Next. So in terms of RMNCH relevant data, 60 countries have data on RMNCH relevant indicators. The date ranges from 2013 to 2023, but only Philippines has data from 2023. And I've already mentioned the indicators, but just to show that data are available by source. So you can look at government expenditure on RMNCH, external expenditure, and private expenditure. The last time I checked, there was no out-of-pocket data available, but this may have changed. And this is all from me. Thank you very much. I see there are some questions in the chat. I'll try to answer them. And I'm going to hand it back to Nouria for our last line.
Thank you so much, Melisa. We are going to have at least 20 minutes for questions, so we will take all of the questions. We just wanted to emphasize that this is one webinar where we start talking about health financing, but we're hoping to have more activities. Certainly next week at the same time, we're going to have 2 country-specific examples in a webinar such as this one, Tanzania and Senegal. I don't know, Peter and Pauli, if you want to put your cameras on. I'm going to stop sharing so that we can all see each other. So this DAC that we have, that we work on, the Data Analysis Center, is made up of a number of people. There's Joe Borghi and Catherine Pitt, who are both professors in health economics and specialists in health financing, who are working in this DAC. There's myself and Melisa, whom you know already. And there's Peter and Pauli, who you can see now. Peter is a lead in Tanzania, but supports other countries as well. And Pauli is a lead in Senegal and supports other Francophone countries. You see that we are trying to be able to cater both to the Francophone world and to the Anglophone world. And this team is the one that is, if you wanted to reach out to us to understand things better and to undertake any of this analysis, please reach out to any one of us. But next week, Peter and Pauli will be presenting what all of this analysis actually means from the perspective of Senegal and from the perspective of Tanzania. They will show you what data they've used and the results they have by doing various analysis with this data, and what it is that you can say once you've done this analysis to governments and to whoever is meant to be supporting RMNCH. So that's the first next step from our perspective, is this workshop that is taking place next week. And Coretta is going to be sending you an invite. If you want to join us, please do. The other thing that we're going to do is we're going to have a face-to-face workshop, one in Senegal and one in Tanzania, that is going to be training people in undertaking the analysis themselves. If you were interested in participating in this face-to-face workshop, that is probably going to be taking place in May and June, May in Senegal and June, we suspect, in Tanzania, please let us know, let the countdown know. We haven't got a lot of funding, so we're trying to understand what the interest is and whether we could find a source of funding to respond to the demand. So next week is about Senegal and Tanzania. How can you translate all this into policy relevant work about learning how to do this analysis yourself? If you wanted more webinars, if you wanted us to go into further depth in particular aspects, it's very easy for us to do that. So just email us either at Catherine Pitt, and I'll put my email in the chat box, and we will be very happy to set it up. This is it from us. I know that there are some questions in the chat. If you want to ask a question, I will call you and ask you to pose your question. In the meantime, Melissa, I wonder whether you can answer Dawood's question on whether the data is health specific, etc.
Yes, Daoud, merci pour la question. Oui, la réponse est oui, les données sont spécifiques aux thématiques santé, par exemple la planification familiale, mais aussi la santé de la reproduction, santé maternelle, néonatale, infantile, etc.
Under 5 health, etc. This is for health.
Albert, we will need to reach out. Yes, Albert, please reach out so we can help you retrieve data for your country.
And as to the exact date for the in-person workshops, we haven't got them yet. We're waiting to get some information about venues, etc. But it's going to be May and June next year. No, actually this year, 2025. Yeah, this year. Alfred, you can unmute your microphone and ask your question in either French or English.
Yes. Sorry, I'm in a very difficult network, but I just want to say thanks. And Peter has been working with us in Liberia too. And the issues have been lack of data from government side. Getting the data has been very difficult. We know that most of the data, they have expenditure will be done by international donors and for the RMCH. And the issue is I missed part of the thing because of the internet, but Liberia will have interest in participating in one of the trainings, either in Senegal or in Tanzania is the English one, then they will be fine. And the issue is, do you have data for Liberia too? Because the data we have is very limited, and we use it for last analysis in the investment case and in the investment case or evaluation. So I just want to know whether there's data for Liberia to analyze using the system you talk about. Thanks.
Thank you, Alfred. Peter, do you have the answer to that question as to whether data is available in Liberia to undertake this analysis?
Yes, Nouria, and thank you, Alfred, to hear from you. Yes, we did the previous analysis in Liberia, which actually was up to 2019. And we haven't gone back to ask whether we can get some additional data. I remember I communicated with you, Alfred, if there could be additional data post 2019 in terms of financing and the outcome, so as to do some sort of subnational analysis. But you promised to look at it. So if you can get, then it will be much appreciated. We can work with you.
Okay, thank you. So the HRES is ongoing, and the next source of the data is getting it from government expenditure and donor expenditure, which I'm still trying to do. And pulling our data from these sources is a bit difficult. But as we enter the new year, particularly with a new government coming, it was difficult to penetrate through some of these the systems. So now the government is, I think, almost 1 year old now. So I'm sure things are going to be flexible. So let's look up to January. Thank you. Asante.
Thank you, Alfred. Melisa, you wanted to comment on this?
Yes, thank you very much, Peter. Alfred, just to complement what Peter said, for the CRS, the creditor reporting system, that data will be available for Liberia. So it will only be for aid, but aid for RMNCH from the Muskoka 2 algorithm will be available from Liberia. And if you're interested, you can download the global data set and see what's available. And if you want the expanded version, you can get in touch with us.
Thanks so much. I appreciate it. Yeah.
Thank you, Melissa. Daoud?
Yeah.
Monsieur Daoud Kone, vous pouvez vous... Voilà, allez-y.
Mr. Daoud Kone, yes, good afternoon. Thank you for your presentation. Thank you very much. I'm Kone Dauda from Côte d'Ivoire. I would like to better understand. Do you think that from this platform, you extract data and you try to process data from this from Strata, or are we going to make the analysis from the platform? Pauli, can you answer this question? Yes. No problem. Good afternoon, Mr. Daoud. Good afternoon, everybody. Yes, the data analysis can be done on the platform, but it will be limited. But it is possible to extract data on from Excel or CSV, and you can do the rest on Stata, or you may continue on Excel, depending on what you wish to do.
Merci bien.
Thank you very much.
Merci,
Thank you.
merci Pauli.
Thank you, Pauli.
Dr. Elhaj Malik Sila.
Dr. Elhaj Malik Sila, over to you.
Je vous en prie, allez-y, votre micro est
Kindly
ouvert.
unmute your microphone.
Mais on ne vous entend pas.
We can't hear you, gentlemen. Mr. Elhaj Malik Sila.
Non, désolé, on ne vous entend pas, monsieur. Je vois qu'il y a une question de Tadele.
This is the question from Mr. Tadele.
You're not familiar with the CRS.
You're saying that you're not familiarized with CRS. Yes.
Have a look at the CRS for Ethiopia. I'm sure that it will provide interesting insights into what is being allocated. Dr. Elhaj, est-ce que ça marche maintenant? No.
Mr. Elhaj, we can't hear you. Sorry for that.
Peut-être vous pouvez écrire la question.
Maybe
Oui.
you can write down your question on the chat box.
Oui, écrivez la question si vous voyez que ça marche pas.
Kindly jot down your question on the chat box.
D'autres questions
Any other question in the meantime?
Ce qui serait très intéressant pour
What
nous,
would be interesting
vous avez vu
for
que j'ai
us
mis
is
mon
that you
adresse
saw that
email dans
I've put my
le
email
chat.
address in the chat
Ce qui serait
box.
vraiment intéressant pour
What
nous,
would
c'est
be
que
interesting for
vous
us
nous
is
disiez
that you
si
should
vous
tell us
voudriez
whether
plus de
you
webinaires
would like
et
more
si vous voudriez plus de
webinars, or
webinaires,
if
sur
you
quel
want
sujet voudriez-vous ces
more
webinaires?
webinars,
Est-ce qu'il
on
y a
which
quelque chose
topic.
dont on a
Do you
parlé,
have,
mis à part bien
is
sûr
there
le webinaire
anything
qu'on
we
va avoir
did
la
not
semaine
talk about
prochaine?
except the
Est-ce qu'il y a
webinar we'll
quelque
have
chose dont on a
next week?
parlé
Is there
qui vous
anything
intrigue et qui
which
vous
is
serait
still
utile de mieux comprendre?
useful, something
Si c'est le
you wish
cas,
to better understand?
merci de
If
le mettre
so,
dans le
kindly
chat. Je vois, merci Albert, je vois que vous
write
avez
it
mis
on the chat
a
box.
webinar
You
on
said
data
webinar on
extraction
data
could
extraction, for
be
instance.
useful to you. Alfred, can I ask you?
So much.
Albert, sorry. Albert, it would be good if in the chat you can say what you mean. Data extraction, is it how to use the data, whether from the CRS or from the WHO expenditure, and work on it? Is that what you mean, Albert? Do you want to come in? And then Dr. Hadj, I'll come back to you. Je reviens à vous.
Ok. Lucila, j'ai vu que nous avons fait un exercice
Yes,
dans
we had an
quelques années
exercise
passées,
some years
ce qu'on appelle
ago
NIDI.
with NIDI.
That was like a family planning investment of like funding allocation. It's available on that. So for any financing data collection through the Ministry of Health and Partners, there's always been a challenge to really have data from the ministry. I don't know why they really kind of hide the information, financial information to partners, even researchers. And I would be keen to really know what do they report within the, you call it CRS, if they do report in there, or even in a with the WHO, so that you can really access it, produce something out of it, and then let them know, look, this is what you are reporting, and it's not showing any visibility in terms of transparency toward health, like spending health expenditure compared with other countries, and you not say that the country is doing well. You are doing well when you are hiding information from other people to appreciate how best Rwanda is performing. So that would be a good, even a good finding, just to let them know that they are not doing it the right way, whereas other countries are really showcasing and reporting on the health expenditure. You cannot prove them wrong until you have those those proof from these reliable sources such as WHO, whereby they're even mandated to report to, even this CRS, if they are also subject to report it to. So that is my interest in it, and I wish you could produce something out of it and show this to the Minister of Health. We also have a technical working group about health planning and financing in Rwanda, and that is chaired by the Minister of Health. In case they can just know that we are interested and they are producing something out of what they report in as data, they would be more interested to motivate to report more in the system. That's my think on this.
Thank you.
So any data that is available, we would like to access it so that we can produce something to share with the ministry. Thank you.
Albert, can I suggest that you reach out to maybe to myself and we can continue this conversation?
Yeah, no
Can be
problem.
done.
Yeah,
Dr. Al-Haji, do you want to come back? Vous voulez essayer?
D'accord. Donc, merci beaucoup. Je voudrais
Thank you.
demander, est-ce que
I would like to
les
ask
données
whether these
contiennent les
data
prix
include
par les patients pour accéder à
the
certains services? Par exemple, dans le
out-of-pocket
cas du
paid
Sénégal,
by
nous avons
patients.
pris,
In Senegal,
nous
we
avons
have
pris le mois
published
passé
last
un article
month
sur la CRM.
an
La
article
CRM
on
qui est supposée
the
d'être
CRM,
gratuite au Sénégal,
which
mais
is
pas tout le monde
supposed to
qui
be
peut
free
payer
in
pour accéder
Senegal, but
à ce
women
service.
are paying
Mais
in
ce qu'on a
order
vu,
to
c'est que
have
chaque
access to the
hôpital, chaque
surface.
structure
But each
sanitaire donc fixe le montant de la CRM
health
et donc
center
c'est
will
eux qui
have
décèdent le
the
paiement. Et
amount,
donc,
and
dans
there
ce
is a
cas
kind
où
of
le
disorganization,
paiement est
and the
désordonné,
payment
comment vous
is
faites
not
pour
done in
collecter
an
ces
orderly
données et
manner.
les
We wish to have
gérer,
more
quoi.
data in
C'est ça ma
order to
question.
have a better management of this
Si, Dr. Haji,
service.
Paoli, je me demande si je peux me
Doc
tourner vers toi
Pauli,
pour
Pauli,
répondre
what can you
répondre à cette
say
question.
to Dr. El Haji?
Oui, cette question elle est un peu difficile à répondre. L'une de nos sources, principales sources de
One of
données,
our
quand il
sources of
s'agit des analyses
data
pays,
for country
au-delà
analysis,
des plateformes que
beyond
nous avons eu à
the
partager avec
platforms
vous,
we have
c'est
shared with you,
les comptes nationaux
is
ce sont les
national
comptes nationaux de la
accounts,
santé fournis
health
par le
national
ministère de
accounts
la
that are
Santé
provided by the Ministry of Health.
et oui, qui sont
And
basés sur des
these accounts are
estimations
based
réalisées à
on
partir des enquêtes,
estimates carried out
les
from
enquêtes démographiques de santé et les
health
enquêtes telles que l'enquête
surveys
harmonisée sur les conditions de vie des
and
ménages.
harmonized
Et
surveys on living
sur la
conditions.
question
Now,
des paiements effectifs
regarding the
réalisés dans le
out-of-pocket
cadre que
payments,
vous exposez actuellement,
in the
il est
case you are talking
difficile,
about, it is
bien
very
entendu, de
difficult
retracer
to
cet
track
état de choses au travers
this
de ces données,
situation
ne
with this
serait-ce que
data,
peut-être de faire une enquête
because we need a
particulière
specific
pour mesurer le
survey
phénomène.
in order,
Donc,
in order
essentiellement,
to
nous
measure
nous
the
basons sur les
phenomenon.
données fournies
But
par
we
les pays
use
eux-mêmes
data that
à
are provided
partir
by
des comptes
countries
nationaux de la
themselves
santé.
from national accounts,
Oui,
health
malheureusement,
national
la question
accounts.
spécifique,
Unfortunately,
merci
the
Paoli, que
specific
vous
question
posez,
you are talking
Dr.
about
Al-Haji, est vraiment une question qui est très
is
importante, mais
very
qui requiert
important,
une
very
analyse,
relevant, but it
une
requires
enquête
a
au niveau
specific survey
de la population et des
at the
centres de
country
santé
level,
pour
at the
pouvoir
healthcare centers, in
détailler
order
ces abus
to know
euh,
about those
au niveau
abuses
des user fees.
for user fees.
D'accord, merci beaucoup.
Thank you very
Merci à
much.
Est-ce qu'il y a
Any other
donc on voit à travers les
question? We
messages qu'il y
see
a vraiment
through
beaucoup
the
d'intérêt
messages
sur
that we have much
comprendre
interest in order
le
to understand
processus d'extraction des
the
données.
process of
Et oui, le
data
CRS existe pour
extraction.
le Mali aussi,
CRS does
pour
exist
comprendre ce
for
processus
Mali.
d'extraire
We
les
want
données,
to
quelles sont les
understand
données
this
vraiment
process.
dont
What
on a
are the
besoin
data
pour
we
faire
need
les analyses au niveau
in
du
order
pays
to
et
make
comment
analysis at
peut-on
the
s'y
country
prendre,
level?
quelles sont les
How can we do
difficultés
it? What are the
au niveau
difficulties we
technique,
face
mais aussi au
at the
niveau
technical
politique,
level,
parce
but also
qu'avoir
at
des
the political
informations,
level?
souvent,
Because if we want to have
c'est
information,
révéler des choses qu'on n'a
it
pas
means that we
toujours
could
envie de
reveal
révéler en tant que
things we
gouvernement,
might not
car
want
ça
to
met en
disclose.
exergue
And this
certaines
highlights
inéquités
some
et certaines
inequalities
inefficiences dans
and
dépense de
some
ressources. Donc, c'est vrai que c'est
deficiencies
parfois
in
difficile
resource spending.
d'avoir ces informations.
That's why it is
Donc, on va
very
avoir un
difficult to
webinaire
have access to
sur
this
ce processus
information. Yes,
d'extraction
having
et
a
sur ensuite
webinar
peut-être
on
l'analyse
these
qui en
extraction
découle.
processes and the analysis.
Merci pour ceux qui disent qu'ils sont
Thank you for those
intéressés
who are
par
saying that they are
ce
interested
travail pour leur
by
pays
this
spécifique. Je vais vous demander, s'il vous
process.
plaît,
I will ask
de
you
m'envoyer un email.
to
Je demanderai
send
à tout le
an
monde de m'envoyer un
email.
email
Yes,
pour qu'on puisse
please send an
commencer le
email
dialogue
that we can
sur
start the
sur vos
dialogue
pays et essayer de
on
vous
your
soutenir.
specific countries and
Monsieur
provide
Daoud,
the
je ne sais
support.
pas si
Mr.
votre
Daoud,
main
I
est
don't
une
know
nouvelle main ou une
if
ancienne main.
this hand
Oui,
is
oui,
a
c'est une nouvelle main.
Ah,
new
pardon,
one
je vous
or
ai
an
ignoré en
old
pensant
one.
que c'était une
Yes,
ancienne main.
I
Allez-y.
thought it
Non,
was
c'est une
an
nouvelle
old
main.
hand. It's a
Relativement
new one,
à
and
notre collègue qui est intervenu
it is for our colleague
relativement au paiement
for
direct des ménages. C'est vrai que le paiement direct des ménages est
household
capté
payment
par
because this
l'Institut, par les
is
différents instituts nationaux de statistique.
managed
Et
by
il en existe des
Statistic
bases de données.
Institute.
Je veux
We
savoir,
have.
est-ce que ces bases de données-là
Do you
sont
think that those
disponibles à votre niveau?
databases are
Voilà,
available
pour
at
pouvoir
your
comparer,
level
pour pouvoir faire une
so that
comparaison au
we
niveau des
can make a
différentes catastrophes.
comparison at
Merci bien.
the country level?
Merci, Pauli, je reviens à toi.
Thank
Merci
you,
beaucoup.
Pauli. Pauli,
Super.
over to you once again for this country.
On t'entend pas bien là.
We can't hear you. Sorry for that. No, no.
Vous m'entendez?
Peut-être?
Pourtant, je suis sur mon ordinateur.
Non.
Vous m'entendez?
Direct on the
Oui, plus ou
microphone,
moins,
please.
vas-y.
D'accord. Donc,
Okay.
pour ce qui est des paiements directs des ménages,
For
oui, vous l'avez dit,
household
les
out of pocket,
nationaux
the
de
National Statistic Institute may have some
Et
information.
pour ce que je sais, au niveau
But
de
as far
l'OIMO,
as
nous
I
avons
can say, in WIMO level,
harmonisé
we have the harmonized survey
conditions de vie de ménage
for
organisé par
household
la
living
commission
condition, which has been organized
se
by
charge
the WIME Commission. They are in
voilà, de faire un
charge
point
of
sur les paiements directs effectués par les
surveying
ménages
out
et
of
aussi
pocket payment,
connaître
in,
peut-être quelle est
but
la
also to
couverture
know what
assurance
is
maladie au sein
the
de la population. Donc, il y a
health
cette
insurance
enquête
payment. We have this
qui est réalisée
survey that was
avec une
carried out
fréquence de 2 ans
every
par
2
défaut.
years,
Et les données sont
and data
disponibles
are
sur,
available
sur un site
on a
dédié à
specific
cela. Et vous,
website
tout comme moi,
for
pour la
the
plupart
WIME
de
countries for most of
2018 à 2022.
2018 to
Donc, pour
2022.
certaines années,
For some years,
ce sont des enquêtes à
these are
plusieurs vagues. Donc, 2018,
several
première vague
series of
participée en 2018, la deuxième vague en 2021.
information
Vous avez
2018,
beaucoup de données
2021.
de part et d'autre. Donc,
So you
ça,
have
c'est déjà
the
aussi
data. This
une
is
source
one source
pour
of
ce qui concerne
data
le paiement
for
direct des
out-of-pocket
ménages que
payment.
vous pouvez exploiter.
And you
Vous
may
faire des analyses
use
plus
such a
approfondies.
source of
Et également,
information.
vous pouvez
But generally
bénéficier
speaking,
de ce qui est fourni par
you may
et
use
aussi
what
des
is used by
rapports
Static
du
Institute
ministère de la Santé.
or the Ministry of Health. They may have such type
Et
of
peut-être que
information
dans
as
les
well. And
exemples que
maybe
vous allez donner
in
la
the
semaine prochaine,
instances you
toi,
will give next
Paoli,
week,
and you, Peter,
you, Pauli,
ce serait une bonne
Peter,
idée justement de
it would
mettre
be a good
de
idea
mettre en exergue les sources de
to
données que vous avez
highlight the
utilisées,
source of data
mais
you've
aussi
been
comment
using,
vous avez fait pour
but
les
also
obtenir.
how you manage to
That might be
have access
something
to those
interesting,
data.
Peter, anyway, we can talk about that later. We've come to the end of our session. I would like to thank you all very much for joining us today. We hope it has been useful. We hope to see you next week when Peter and Pauli will be illustrating all of this into the specific case studies. And I'd like to thank you, Melisa, for the presentation and the countdown for organizing this and for the interpretation support and all the logistics. Thank you very much. Don't hesitate to reach out to any one of us via email, and I hope to see you next week. Bye.
Thank you.